I'd like to invite Jamal from Advanced Bionics. You can see his surname on the screen, Begovic, but so that's about as good as I can do. But Jamal's going to tell us about the advanced bionic implants, and then we'll be seeing some of them implanted this afternoon. So I'll hand you over to Jamal now.
Thank you very much for this introduction. Good afternoon, everybody who is online. So I'm Jamal Gazbegovic from Clinical Research of Advanced Bionics, and I will present some clinical results of the HiFocus Mid-Scala Electrode. It's actually the electrode which Professor Lennartz from Hanover has implanted this morning. Before I come to the clinical results, I will first rephrase a couple of features of the electrode design itself. While developing the electrode, we did an extremely extensive literature review, and we're trying to understand what is an electrode that would fulfill the needs for a traumatic insertion. According to surgeons, it would be an ideal electrode would be an electrode that preferably will not touch any of the cochlear structures during the insertion as well as afterwards. So it is well known from the literature that perimodellar electrodes are quite prone to damaging the modellar structure. They tend to dislocate after a certain point, and then the same has been, a similar has been shown for lateral wall electrode, that after certain insertion depth, the friction forces on the spiral ligament increase exponentially. And so the concept of the mid-scala electrode was to have a kind of floating electrode concept where the electrode would not touch the lateral nor medial wall during insertion as well as afterwards. The length of electrode is designed so that it would, in average, cover 1¼ turn. Basically the biggest part of the spiral ganglion population. It is suitable for 0.8 millimeter cochleostomy or round window insertion as well. The tip of the electrode is 0.5 millimeters, and the most proximal end is 0.7 millimeters. The electrode has a stylet to keep it straight, is pre-bended, and it can be inserted as a freehand, as we have seen this morning done by Professor Lennartz, or using the insertion tools. So during my talk, I will go through a couple of clinical studies that are being done, and that should answer questions on where does the electrode indeed position in terms of scala location, how traumatic is this electrode, then the electrode stability. Then we will also see the potential of the electrode for preserving residual hearing. And then on the last part, we will see how usable is the electrode and the tools to fulfill surgeons' individual approaches. I'll start with the first aspect. On the scala location, a couple of months back in 2014, there has been a paper that came out from the Freiburg team, Hasepas and Professor Aschendorf. They have investigated the HiFocus Mid-Scala Electrode in 20 fresh frozen temporal bones. The Mid-Scala Electrode was inserted in 10 of them through the cochleostomy and in 10 through round window. And then the investigation of the scala location was done on 2 ways, by the means of rotational tomography that was extensively described in literature by the group from Freiburg, and by the histology. And if you look at the results, actually in 19 of the temporal bones, or 95%, there was any kind of trauma according to the Esragi scale found. There was one pure scala vestibular insertion in one of the cochleostomy inserted temporal bones, and in one of the specimens a slight elevation of the basilar membrane was found. So looking at the electrode stability, or the potential of the electrode to migrate or move, this was also mentioned or discussed this morning in the morning session during the live surgeries. So we are running these days a prospective study to look at the at the electrode stability, and at the same time to validate a special electrode visualization technique, which was also shown as an issue this morning. The methods, the electrode imaging is based on a fusion of preoperative MRI and postoperative cone beam CT. And this technique was developed in Maastricht here in Netherlands, and the accuracy of this technique is actually around 0.2 millimeters. So one can rely on the accuracy of 0.2 millimeters in terms of identifying the electrode location. Here are a couple of images that are showing HiFocus Mid-Scala in situ or in vivo in real patient. So we do see on the right-hand image on the basal projection that the electrode in the most basal part sits pretty well, is slightly in a perimodellar position, which is by the nature of the insertion. So the electrode in this case is inserted through the round window, while in the remaining part of the cochlea, it is resting in a mid-modellar position as expected. And on the left-hand side, so we see a nice pure scala tympani insertion. Looking at the stability results, it is reported in literature that that extrusion of an electrode is not an exception, and particularly straight electrodes are more prone, as this was discussed this morning, to extrusions and movement afterwards. In this paper that is indicated here, patients with drop of performance were extensively reviewed, and in this group of population, in 30%, an electrode extrusion was the primary reason for drop of performance. So within this study, the fusion of two cone beams was done for identifying and measuring the electrode migration. And the blue cone beam CD was done immediately, well, 1 day after the surgery, and the red one is the cone beam done 90 days or 3 months after the surgery. And both images were fused, and then the anatomical structure was removed, so just to investigate actually the electrode movement. And in the first 6 patients, we are seeing an average electrode movement of 0.2 millimeters, which is clinically not relevant at all. And looking at the potential for hearing preservation of the mid-scala electrode, I'll like to present data from, and thanks to Professor Dan Jiang and St. Thomas's for contributing to this work. So these are preliminary results of 23 patients. Among them is one bilateral user, so I'm reporting on 24 years. So we see the average preoperative audiogram. So this population has some residual hearing in the low frequencies. And during the surgery, no steroids were used. And the results that I'm going to show in the next couple of slides are showing the latest pure tone audiograms that are ranging from 21 days to 344 days postoperatively. Looking at the 250 hertz, so we see on the x-axis the preoperative thresholds, and on the y-axis the postoperative thresholds. We see that majority of patients are within the range of 15 dB hearing preservation. Looking at 500 hertz, we see similar pattern, and the same for 1K. If we combine these results and look at the average change in thresholds, postoperative versus preoperative, so we see that at different frequencies we do remain within the classification of almost complete hearing preservation with the mid-scala electrode. Looking at the flexibility of the electrode itself and the tools for fulfilling individual surgical needs, we are conducting a surgical survey that involves 23 surgeons coming from 14 centers, and I'm happy to present data on 105 surgeries. So looking quickly on the participants itself, so all of the surgeons do have some prior experience with advanced Bionics electrodes, and centers participating are mainly in North America, some of them are in India, and we have few in Europe. Then looking at the rate of deviation between the insertion access to the between the access to the cochlea. The question was for surgeon, what was the intended insertion for your surgery today? And we see in this group of surgeon, 78% were aiming for a pure round window insertion, 14% for modified or extended round window, and 8% aimed before the surgery for a cochleostomy insertion. And then we were looking for the rate of deviation, so we asked the same question at the end of the surgery. We had overall 19% of deviations, which were mainly due to anatomical reasons, where typically surgeons had to drill up slightly the round window niche, sorry, not the niche, the round window itself, so for being able to have a good view to the round window niche itself. And that's basically in line with the literature reports, so that in some cases it may not be possible to access the round window as initially planned. Looking at the rate of the usage of insertion tools, so the electrode mid-scala can be inserted well purely with a freehand technique or using the insertion tools. And prior to surgery, this particular group of surgeons, so more than half of them, so 64% were aiming for a freehand insertion, as we have seen this morning done by Professor Leonards, and 36 were aiming to go for the tools. And then on spot, so in those 105 surgeries, there were 10 deviations. So, and they went both ways. So in some cases, the surgeon, if he was intending to use the insertion tool, he had to he switched over to freehand insertion, and also some of those who have thought to do the freehand, so they have basically decided to give the to give it a try with a tool. So it goes both ways. To sum up my talk, we have seen that the HiFocus Mid-Scala Electrode is indeed an atraumatic electrode and has a high rate of scala tympani insertions and hardly any dislocations in these studies that I've shown. It appears to rest stable, not to migrate in this, based on this preliminary data, which is obviously extremely important, particularly for small children, as any electrode migration may take weeks or months to identify, particularly in the pediatric population. It has a good potential for hearing preservation, although there are a couple of studies running also with true ES candidates to confirm these initial results. And we do see best compromise between electrical full coverage and minimal trauma, with a consistent insertion depth of around 420 degrees and lowest standard deviation reported in the literature. And in terms of tools and the electrode itself, it appears to be flexible for round window insertion, cochleostomy insertion, using tools, or completely freehand insertion, depending on surgeon's preference. Thank you very much.
Oh, thanks very much for a wonderful presentation. You must have got German or Swiss railway genes in your running in your blood, because that was perfectly to time. So I don't know whether. Okay, so thank you very much indeed.